In this podcast, we're going to consider the effects that hypoxia can have on the body. And I think the first thing to say about the effects of hypoxia is that hypoxia, if it's caught in the early stages, the effects on the tissues of the body are reversible. But later on, as the hypoxia is prolonged, there's going to be more and more damage. And the brain is particularly prone to hypoxic damage. Do you remember the J.S. Haldane statement? Hypoxia not only stops the machine, but will wreck the machinery. And as we said, hypoxia first will stop the machine. It will stop it working properly, but it will then go on to wreck the machinery. It will then wreck it in time. So hypoxia, a hypoxic patient, is critically dependent on your clinical intervention at as early a stage as possible. If you recognise a patient is becoming hypoxic and you can oxygenate that patient, then you will prevent permanent hypoxic damage. Anyway, let's think about what we see with hypoxic patients. And probably the best known clinical feature in hypoxia, the best known effect of hypoxia, is cyanosis. Now, cyanosis is that characteristic bluish, purplish appearance on the surface of the skin and mucous membranes. And this actually occurs as a result of reduced, that is deoxygenated hemoglobin, in the capillaries of the body. It's caused by the deoxygenated hemoglobin. Now, I remember this always confused me when I was learning about this, because I knew that reduced hemoglobin was dark red, but cyanosis was a bluish, purplish colour. And I still don't understand the reason we get this fully, but what happens is, when the deoxygenated dark red blood is seen through the human skin, that is perceived as a bluish colour by the human eye. So don't worry about the physics of it, but that's what it is. So really, when you're seeing that bluish tint through the skin, what you're actually seeing is the presence of deoxygenated dark red blood in the patient's capillaries. It's just the way the human eye detects it through the skin. Cyanosis is not actually a particularly sensitive indicator of hypoxia, and studies have shown that even relatively experienced people can miss hypoxia until it's at a fairly late stage. So probably as a rough rule of thumb, I'm going to detect the presence of clinical cyanosis when the oxygen saturations have already dropped down to about 85%. So the patient is already a bit hypoxic by the time we can detect it using cyanosis. Ideally, of course, we would detect it before this stage and prevent cyanosis. And it's a clinical feature we would hope not to see, because we've already detected the developing hypoxia, probably with pulse oximetry, and prevented it from developing. It's been estimated that clinical cyanosis is only present when there's as much as 5 grams of deoxygenated hemoglobin per 100 mils of capillary blood. So the blood is already fairly deoxygenated. Cyanosis is often described as central cyanosis or peripheral cyanosis. It's worth understanding the difference. Central cyanosis is caused by hypoxemia. It's a lack of oxygen in the blood, and I guess you could say it's the more serious form of cyanosis. And we can see it in the lips, the tongue, the face, the neck, the centre of the chest. It's central cyanosis. But peripheral cyanosis is seen in areas like sometimes the tips of the nose, the earlobes, the fingers. And the peripheral cyanosis, you can even get that when someone's very cold, actually. They can look cyanosed in the periphery. And the reason for the peripheral cyanosis is the reduced rate of circulation of the blood through the peripheries. So it's more an indication of peripheral perfusion, really, rather than hypoxemia. Although, of course, it will be present in hypoxemia as well. But the key thing in hypoxemia is to look for the more dangerous central cyanosis. But in the peripheral cyanosis, what's happening is, if the blood is circulating through the capillaries very slowly, then can you see there's more time for that blood to give up its oxygen to the tissues. So as the blood circulates through the capillaries and the tissues slowly, it gives up more oxygen, and you get a greater proportion of deoxyhemoglobin, of the dark red deoxygenated blood. And of course that's what gives rise to the clinical feature of the cyanosis. So the peripheral cyanosis is more a state of the circulatory system, the slow circulation, whereas central cyanosis is a hypoxemic and a dangerous clinical feature to observe. Let's think about the effects of hypoxia on the central nervous system. Of course, the brain is the most sensitive tissue to hypoxia. And we could maybe say that mild hypoxia is saturations below 85%. And that will cause fatigue, headaches, tiredness, lethargy, nausea. Can cause vomiting and dizziness and some confusion, because the brain is not working properly because of the low levels of oxygen it's receiving. We could probably say that moderate hypoxia is saturations below 75%, and all these confusion and lethargy and headache features can become much worse. There'll be severe mental impairment. And also at these levels, the ability of the brain to detect pain is reduced. There'll be reduced pain sensitivity. And we could call severe hypoxia to be saturations below 65%. Now it's hard to get precise figures on this, but you know, at 65%, the patient will have severely reduced levels of consciousness, if not unconsciousness. At these kind of levels, below 65%, you can get insults to the brain causing convulsions. These patients can fit. This is what happens when a patient faints. If a patient faints, if they have like a syncope, an acute cerebral hypoperfusion, if someone faints and you lie them down, the blood and the oxygen is going back to the brain. But if someone faints and they're not able to lie down, and if they're propped up or sitting up, then they can start fitting, because the level of oxygen in the brain will carry on dropping, because you haven't got the gravity assist feed of blood and oxygen to the brain that you have when the patient's lying down. So when patients faint, make sure you lie them down, otherwise they can start fitting. So very low oxygen saturations, below 65%, convulsions, developing coma, and of course death of the brain will ensure. This is a life-threatening condition, of course. And of course the central nervous system cells can recover with short periods of hypoxia, but you have to intervene quickly to keep the patient oxygenated. And hypoxia can also give rise to cerebral edema. If patients have had a period of hypoxia and have then been resuscitated, there can be low levels of consciousness for a few days due to cerebral edema. Because what happens here is when the brain is very hypoxic, there'll be this compensatory cerebrovascular vasodilation. The arterioles will dilate. That will increase the pressure in the capillaries, and more tissue fluid will be forced from the capillaries into the interstitial spaces in the brain, the vasogenic cerebral edema. And there can also be the cytotoxic cerebral edema, where there's not enough oxygen getting to the brain cells, so not enough energy is produced. That means the sodium-potassium pumps can't work normally. That means sodium accumulates inside the neurons. Sodium attracts water, and that causes the neurons to swell. So cerebral edema is a recognized complication after a period of hypoxia. And these patients might need to be managed in an unconscious state for several days until they can recover. And the other thing I've seen in acute hypoxia, when there's a very extreme acute hypoxia, is you're going to get a tachycardic compensation usually initially, but then as the myocardium becomes hypoxic, it becomes irritable, and you start getting ectopic beats in the myocardium, and this can eventually develop into ventricular fibrillation. So if someone's acutely hypoxic, the actual immediate acute cause of death will probably be ventricular fibrillation. So hypoxic patients need to be monitored carefully to see what their cardiovascular status is. But get some oxygen into them before this stage, and hopefully it won't develop. And then there's going to be hypoxic damage to other organs eventually. All tissues can be damaged by oxygen lack, but the time taken varies. So central nervous system tissues are the most sensitive, as we've said. I mean, they say that brain damage can start 3 minutes after a cardiac arrest. So central nervous system cells are damaged very, very quickly. The myocardium itself will be damaged after about 5 minutes of hypoxia. Kidney and liver tissues are adversely affected after 10 minutes or so. Skeletal muscles can do quite well. They can survive for a couple hours in the presence of hypoxia. Because we're sometimes, in orthopedic surgery, for example, we use tourniquets and we can leave those on for a period of time. I wouldn't want to leave them on for as long as 2 hours. I'm not quite sure what theatre nurses are currently doing. But certainly you could leave a tourniquet on for half an hour without adversely affecting skeletal muscles too much.